Good evening. Welcome to the 9th annual Vermont Cystic Fibrosis Education Night. My name's Connie Tompkins, and I am on the Family Advisory Board for the CF Foundation here, and I'm the mom of two boys, 8 and 10-year-olds, and an 8-year-old with CF. So welcome to everyone in the room. The event presentations, we wanted to let you know, are being recorded and will be available on the Vermont Cystic Fibrosis Center Advisory YouTube channel. If you knew we had a YouTube channel, we do. And a link will be sent to everyone participating this evening, as well as everyone on the center email list. So tonight, we welcome many members of our cystic fibrosis community. In the room tonight, we have parents, spouses, siblings, grandparents, friends, relatives, school nurses, CF clinicians, researchers, and our 2 keynote speakers who are living with cystic fibrosis. So some housekeeping for the night. For those in the room, dinner will be served during the program, and a cash bar is open in the back, although they do take credit cards too. So tonight we have a couple of quick presentations from a few different people, and then we'll have Dr. Lahiri give a presentation on the Pediatric CF Center, and Dr. Laurie Leclair give a presentation on the adults. And then we'll have time to break and mingle with the different sponsors and tables. And speaking of that, we want to really thank our sponsors tonight. Those are AbbVie, CF Services Pharmacy, Walgreens, Children with Special Health Needs from the Vermont Department of Health, the Cystic Fibrosis Foundation, Chicey USA, Electromed SmartVest, Foundation Care, Genentech, Gilead, Make-A-Wish Vermont, Maxer Specialty IV Solutions, Never Give Up Ever, Team Impact, and Vertex. So you will have some time. Thank you very much, and please go around to visit them. We're very thankful for their support and their willingness to be here tonight. Otherwise, we would not be able to have a CF Education Night. Sorry about that. So this 9th annual event is made possible by the work of volunteer members of the Vermont Cystic Fibrosis Center Advisory Board. Laurie Eddy, the mom of 2 daughters with CF and a member of the advisory board, is going to take a few minutes to tell you about the work of the board. Laurie?
Hello, everyone. Thanks so much for coming out tonight. This is our 9th annual event, and it's about that many years that we've actually had an advisory board. We were formed in 2007, and so it's more than 9 years. And we actually became a nonprofit organization in 2014 so that we could accept some money from sponsors to put this event on and provide dinner for all of you, to give you an incentive to have a date night coming out, which was always, for the last 9 years, one of the few that my husband, who's also here, and I got to enjoy. So thank you all for coming. We are a board of volunteers, and we are made up of adults with cystic fibrosis, family members, of both children and adults living with CF, spouses, and also members of both our pediatric and adult CF centers. The staff are part of our board because we work really closely with them on some of our projects. But our mission is to support and empower the patients and families living with CF through educational events and through our newsletters. So in addition to this event, we've also been doing some other educational events that I know some of you in this room have participated in. One is the CF Connect dinners, which are a smaller event than these annual education nights. They are sponsored by Allergan, and it's just a dinner at a restaurant with no formal presentations, more of an opportunity for folks to get together and talk about the like journey that we're all taking. And this, we've done two. One was in Middlebury, and the last one was in November, was held up in St. Albans. And they're definitely something that we're going to continue doing. We're hoping to do 1 or 2 of those a year and have them in different locations, because we know not everybody lives in Chittenden County that is serves has their care at the Vermont CF Center. And the other education event that we had last year was an opportunity when Dr. Bob Bell, the former CEO and president of the Cystic Fibrosis Foundation, was available to come and do a keynote address about the current research happening through the CF Foundation. And so we took advantage of that opportunity, which was not on our regular schedule of a CF event calendar, but we held an event in order to host him, and did it a little differently, where after his keynote speech, we held roundtable discussions on topics that the folks who registered for the event told us were of interest to them. So we're always open to doing other educational events as they come available. So if you would like to be notified of those kinds of events as they come available, there is a sign-up sheet out on the front registration table for your email address. I was talking to somebody here tonight that once we have your email address, we will continue to send you those invitations. You can ignore them, or you can register for everything we send out, and we'd welcome you to do that. And of course, our CF Connection newsletter, which we just sent out, our most recent issue, which was 18 pages long, full of amazing information of all the great work that's going on. There's something in those newsletters we try to target for every segment of our community, something so that there's something of interest to everyone. Liz Hamill, who's another mom of a daughter with CF, is our editor, and it takes a lot of work. There are so many contributors to this, to each issue of the newsletter, and we do put that out twice a year, fall and spring-ish. So if you would like to, either you can put your email address on there if you're not getting it already, or you can send an email to vtcfadvisory@gmail.com and just put subscribe in the subject line, and we'll put you on the list. If you'd like to join this great party of people who are involved in the advisory, putting out this newsletter and putting on events and doing other projects as they come up, we'd love to have more members. And we do have a monthly meeting that the first Monday of every month is the pattern that we're doing right now. That can change based on our members and availability. And it is done as a virtual meeting, so we use a GoToMeeting. You can log on from computer or by phone, or come in person to the conference room at the Children's Specialty Center. And that's in the evenings from 6 to 7:30. But if you're thinking, I don't want to commit to something that big, there are lots of ways that you can get involved. And the Cystic Fibrosis Foundation has recently really embraced the voices of the cystic fibrosis community. So you're going to be hearing more from them about this community voice. And community voice is an effort for the foundation to include the people who are living with cystic fibrosis on a day-to-day basis in every part of their work, because you are all the experts. So if your voice is not included in the projects that they're doing, then they're really missing the boat. So this project started about 2 years ago, but it was called the Patient and Family CF Advisory. And Preston Campbell, our new president of the CF Foundation, said, that's a stupid name. So they've rebranded it Community Voice, and you're going to see that just happened last month, so you're going to see more about that. Kinds of projects that are involved in Community Voice are things, if you go to the CF Foundation's webpage, you look up Community Voice, you can sign up to be part of it, and then you'll start, there's a question form that says, what kinds of things are you interested in? If you fill that out, you'll start getting emails whenever there's a project that will be around those interests that you chose. So if you said, I'm interested in the care guidelines and educational materials, you might get an email saying, hey, here's a draft of new care guidelines. Would you take a look at it and send us any feedback you have? You can ignore that email, or you can actually look at it and send in some feedback. It's that small of a commitment. Or you could say that you are interested in really participating in more research, and then you'll get emails saying that we've got a project that we need some focus group members or a committee formed, and would you help with that? And again, you can say yes or no, but the first step is just to go to the CF Foundation's website, sign up, and then you'll start getting these requests to participate at whatever level that you are willing. But the important thing is that then your voice will be heard, and you never know what the next request will be. It might be something that really speaks to you, that you have something to contribute. One other way that you could all get involved. Now, the last things I was talking about with the community voice were for the families and people with cystic fibrosis. But now I'm going to talk about advocacy, and that's for everybody in this room. You all, whether you are living with CF or you are a CF caregiver, a health care provider, school nurse, just a friend, you can participate in advocacy, and this is really, really important right now. I was asked to go down in March to the Cystic Fibrosis Annual March on the Hill, and I was not really happy about going because I didn't want to, I was very uncomfortable with it, but it was such an amazing experience because we went, I'm going to tell you, there were, the numbers were about 100 advocates. Now these were all volunteers from 44 states, and they met with over nearly 300 members of Congress in that one day to talk to them about the specific needs of the cystic fibrosis community when they were considering their new healthcare initiatives, or repeal and replace. And so it was a really amazing experience for me, because the foundation told us that this was not political, this was personal. We needed to go and just tell our story about what our community needs were and how important access to the right kind of health care was for our loved ones. And if not everyone's going to go to Washington and meet with their constituents or their congressmen and senators, but there is also the ability to just send emails, send tweets on Twitter, you can make phone calls, and it really makes a difference. So, being from Vermont, it was pretty easy because, what was I going to tell Bernie about healthcare? So that was pretty easy, but they also had us meeting with other members of Congress that were they were all friendly, but a little more challenging in what their ideas of what the healthcare needs were. So I also met with Senator Grassley from Iowa, who wanted to have more information about the importance of Medicaid for people in the cystic fibrosis community. So again, you could get involved as little as you are interested or as much as you're interested by just sending those emails, taking those calls. Go to the CF Foundation's website, sign up for advocacy alerts, and again, you'll get an email saying, hey, we need everybody to make these phone calls or send these tweets. And I hope that you all do that. So I guess we're going to talk to you about more ways to get involved.
Thank you, Laurie. And I'd just like to reiterate that it's really, if any group of volunteers understands that you're going to have ebbs and flows, what is it called? Whatever. Where you're going to get busy with times, with CF care for yourself, friends, spouses, we get it. So they're a very understanding group to be a part of. Next, I'm going to be introducing Jim Gilbert. He's the Development Director for the CF Foundation for the Northern New England chapter. And last August, the Northern New England chapter of the CF Foundation announced that for the first time, the CFF has a full-time development manager living in Vermont. Jim is working with CF event committees, chairs, and sponsors, and he started with the Northern New England chapter in May of 2015. He's been working on the annual fund, the New England Classic Charity Trail Ride, and Great Strides. Jim is originally from Fairfax, Vermont, and is a graduate of both Champlain College and Johnson State College. Prior to joining the foundation, he worked for 9 years at the UVM College of Medicine Development and Alumni Relations Department, and we are very excited to have a dedicated staff member for Vermont. And so we'd like to welcome Jim.
Hi, everybody. I have a soft voice, so I'll try to lean close to this microphone. Laurie, I want you to know I read all 18 pages of that newsletter. That's actually true. The nice thing about being here in Vermont and being back in my home community is all the people I get to meet and the things I learn every time I have a meeting. It's either reading a newsletter, or it's meeting with a parent, or it's meeting with the care center and finding out that there's so much I don't know about the day-to-day things that go into the lives of everyone who's touched by cystic fibrosis. I've been with the foundation for 2 years, and I'm always learning. I'm so grateful to be here back in Vermont. After 2 years in Nashua, I was ready to relocate, and I was grateful that they decided it was time we had a full-time person here. And so far, I've made great connections, meeting with committees and sponsors and our care center, and I'm just glad to be here. I haven't met everyone who's here yet. I hope that you guys will come over to my table. It's the one with the balloons in the corner, so hopefully we can talk and hopefully get everyone more involved. A little bit more about our office. You probably know our chapter is located in Nashua, New Hampshire. We cover Maine, New Hampshire, and Vermont. We have events in all 3 states. We have a full-time person in Portland. I am full-time here in Vermont, and then we have a staff of 5 other people who are in Nashua. As you guys heard already, I work on Annual Fund. I work on Great Strides, Burlington, and Rutland. We have a dirt bike ride in Loudon, New Hampshire at the Speedway. So we have a lot of great events people can get involved in. And I guess the message I want to leave you guys with is, and the reason why I'm here is most of the things you'll hear about tonight, be it drug developments or programs like Community Voice, all the research that's going into the new medicine, it all has to be paid for, and it's my job to try to raise the money. That's what I do. And I don't do it without the help of a lot of volunteers here in this room, great committees who go out into their communities and ask their friends and family to donate. I hope that I can help with that burden. I'd like everyone to be comfortable to contact me. Do you know of a business that you think might do a sponsorship and you don't know how to approach them? Or do you know friends who might be more interested in becoming involved and helping us plan a new event? I would love to be part of that conversation. Whatever we can do to put more money in the hands of the scientists and the doctors and the nurses, that's my number one goal. And I hope that we can all work together to do that. And like I said, I'm over at the balloon table. I hope you guys will come by to see me and have a good night. Thanks.
Thank you, Jim. So next, I'd like to introduce Dr. Lahiri, as if he needs an introduction. He is the medical director for the pediatric pulmonology and professor at UVM College of Medicine. So Dr. Lahiri.
Okay, let's hope everybody can see what's on the screen. I didn't pick those little graphs with the bars, individual bars, because I know nobody could see that last time we did this. So what I'd like to do is kind of review some of our data from the 2015 registry. I know it seems like, okay, it's 2017, why am I showing 2015? That's the last year of complete data that we have. We'll get the 2016 data sometime this summer. And we'll hope to share that as well with any trends that we see. Just want to kind of review the composition of our pediatric team. Most of the faces are pretty familiar by now. In addition to myself, our other providers include Kelly Cowan, Keith Robinson, Jill Sullivan, our pediatric gastroenterologist, and Julie Hounshell. And Emily is our coordinator. And we have had a little bit of a couple of changes in terms of our medical assistant, Andrea, joining us, and Kendra checking people in. And then Maggie kind of officially joining us in the physical therapy realm. You guys can't see this, but I was asked to comment on this. This is a paper that was published last couple of months. About survival of cystic fibrosis. Definitely not going to touch anything now. So this was published in the Annals of Internal Medicine and talked about a survival comparison of patients with CF between Canada and the US. And what this study showed was that the median life expectancy for CF in Canada was about 10 years longer than for patients in the US. So this obviously stirred up a lot of discussion. And why is this? How could this be true? Aren't we doing everything that we can? And there are probably a lot of reasons for this, but it's been actually an interesting topic of discussion. I go up to Canada pretty regularly and discuss things with the team up in Montreal. And so this is the data, really. So in 2011, the median life expectancy between the outcomes that we get from the patient registry in both countries was about 48.5 for Canadians with CF and 36, almost 37 years for Americans. In 2013, that kind of stayed pretty steady, approaching 51 years for Canadians with CF and over 40 for Americans with CF. Well, there's probably a number of different factors that play into these differences, and I don't think anybody pretends to understand all of them. But some of it has to do with the differences in the healthcare system. Like you have a completely socialized medical system in Canada and a lot of different healthcare systems in the US that differ by state. So fortunately in Vermont, we actually have a pretty good system for coverage of healthcare for most children, and I think even better than many states for adults. But in Canada, this is pretty uniform. The population is also very different in Canada compared to the US. Obviously, you're comparing 340 million to 30 million people. So you're going to have a lot of different numbers there. And we also have the size of the registry. You look over 32,000 people in the US registry versus less than 5,000 in the Canadian registry. So, differences can be more difficult to interpret there. A couple of things were pointed out in subsequent discussions to this article. One had to do with the general approach to cystic fibrosis care in the two countries, which was actually quite different 30 or 40 years ago. So in the 1970s, Dr. Swartz could probably attest to some of these things, the push wasn't really for early aggressive nutritional intervention as opposed to really aggressive respiratory care. And in Canada, they were kind of on the front end of pushing for nutritional outcomes being, better earlier, and really rely on that. And we've adopted that. So over the past 20 years, that's been the push for this CF Foundation in the US as well. And I think you guys all hear about it. Everybody who goes to clinic, adult or pediatric clinic, hears about nutrition, hears about the importance of nutrition in maintaining lung function, which then directly can impact life expectancy. So those changes that happened decades ago are what we're kind of seeing right now. The other big difference between the two countries is lung transplantation. So the approach to lung transplantation, which we have we have an expert that's going to talk to us in a little bit, is very different. So the access to lung transplantation is really better for Canadian patients as a whole. There are fewer centers that do transplant, but their criteria that they use to for donor lungs is much different in Canada than it is here. And so it's thought that the access to lung transplantation also has an impact on these outcomes that we see. The interesting thing, I'm going to show you some slides about what kind of therapies are we using for our patients and in the US, is that most of the therapies that you're going to hear about, the chronic therapies for pulmonary disease, are prescribed about half as often in Canada as they are here in the US. It's just interesting. I'm not saying that means anything, it just is interesting. So things like Dornase alpha or Pulmozyme, hypertonic saline, tobramycin, azithromycin, they're not using them as much as a whole, and some of it's related to cost. So getting Pulmozyme covered in Canada is a much different problem than getting it approved in the US for patients. So that's some practical considerations. So that's kind of where I want to leave it. There's really no answer, clear-cut answers to this, but those are some of the things. For those of you who heard about this article or read about a little blurb on the internet, that's kind of like the nuts and bolts of it, and I'm certainly happy to discuss other aspects of it, with anybody in more detail. So let's move on to kind of like how we're doing overall as a center. These you're not going to be able to read that well, so I might just move on to the graphs. It might be better. So people are always asking about, well, what kind of bacteria? Are we seeing any changes in the bacteria of our patients? And this graph, each line represents a different kind of bacteria. The one on the top is Staph aureus, and the next one down is Pseudomonas, and then you see a mix of a bunch of other bacteria that some of you may know and some of you may not know. And you can see that things are pretty stable, like over time. So it goes from 2006 on the far left all the way out to 2015. And there haven't been tons of changes in what we see in microbiology in our patients at our center. That's kind of really what you see nationwide as well. Complications of cystic fibrosis, again, in our center, some of this is due to our recognition of certain complications, that we start looking for things and we'll find more of it. But this just shows certain complications related to therapies or CF itself, like bone disease, bowel obstructions, depression, allergic type conditions that can affect the lung. And then that bottom graph shows how we're using therapies. So each one of those lines represents a different therapy. That top blue line is Pulmozyme or Dornase alpha. You can see some of those other lines, the reddish lines. Azithromycin hypertonic saline use is going up at our center, and inhaled aztreonam, another antibiotic to kill Pseudomonas, is being used more frequently. And you can see that big kind of spike that started a few years ago and then is like at the top of the chart, and that's the CFTR modulator drugs. So like ivacaftor and ivacaftor lumacaftor, meaning that we're really trying to prescribe these for everybody who is eligible to be on them, which is by no means everybody at this point, but that is one of the goals in the coming years of CF Foundation is to hope to provide some sort of combination of medications that may work for every patient. So let's go to specific outcomes here. I'm going to give you a couple of graphs on nutrition. This has been a difficult area for us in general. The growth of our infants and really young kids with CF. We don't have a lot of people in this age group, so any changes, good or bad, kind of have big impacts on how we look on this graph. And we've been a little bit below the national average in terms of how our babies and younger kids are growing. We've had a couple of premature babies that started out a little bit smaller anyway, but it's not really an excuse. It's just like a reminder that we need to work hard to kind of achieve this, because nutrition starts early. I mean, by early we mean at birth, or as close to birth as possible, to have those better outcomes later on in life. This is a body mass index for our patients between 2 and 19, which is the measure that you kind of follow. The goal is to try to have a body mass index greater than or equal to the 50th percentile for your age. And this shows that we're definitely on average achieving that. Like our median BMI is actually at the 60th percentile, which is really, I think, great compared to where we were a decade or a decade and a half ago. And you can see where that top line are the average of the top 10 centers in the CF registry. And the greenish line is the national average, and then we're the red line. So we're in between that. Both the adult and pediatric programs have been focusing a lot on our patients who have diabetes, because we know that diabetes can really adversely impact both your nutritional status and your lung function, and is a really difficult complication for anybody in this room who's dealing with that in a family member or a spouse. But we've put a lot of work into trying to follow our diabetic patients, and really are performing at like a top center program in terms of how our diabetic CF children are growing. So we seem to be doing really well there. I'm going to move on to lung function. So obviously we're not including people under age 6, because not every child under age 6 can do lung function testing. We start kind of playing around with it when they're 3 or 4 years old, depending on who wants to cooperate or not. And by the time you're age 6, most kids can do lung function testing or spirometry. And you can see that we've had kind of a nice steady increase in our lung function numbers over the past few years, and we're kind of performing as well as anybody else in the country in that regard. I think this is one of the reasons, we've kind of talked about this over the years, that we tend to try to, as a center, both the adult and the pediatric programs, we have a really, I think, try to treat people early before things get too out of hand. And so we end up, an exacerbation is kind of a flare-up, or when you're having a drop in your lung function or more symptoms. And we tend to treat people for that more than other centers in the country. And I don't think that means our patients are sicker. I think that just means our signal to start treatment is maybe a little earlier than some. And I think that probably is a good thing in general. Moving on to infection a little bit more. So Pseudomonas, probably everybody in the room has heard about Pseudomonas, which can be associated, if you have a chronic infection with Pseudomonas, with decline in lung function. And we actually, at least in the pediatric age group, have had sort of declining rates of Pseudomonas right at the national average right now. So we've been pretty happy about that. And in our youngest patients, we really haven't been seeing it as much, which is another good thing. It could be a fluke, but we'll take credit for it, I guess, at this point. And then MRSA, or resistant staph infections, which is another concern for a lot of people. This is around in the community. So the background, if you swabbed everybody's nose, depending on where you are in the country, the rates range anywhere from 15 to 60% of people have an infection with this. So it's easy to find and get, but it's hard to get rid of, especially if you have cystic fibrosis. But our rates have been pretty stable, and actually are a little bit better than the national average in this standpoint. And then about prevention. So these are some areas that I just wanted to highlight quickly. So screening for diabetes. We're supposed to screen every child for diabetes at age 10 and up annually with an oral glucose tolerance test. So that's that super sugary drink that most people don't want to drink, and requiring 2 blood tests to measure sugar levels. And this is an area where I think we kind of continue to have some issues. It's hard to get people in for this testing. People don't want to do it. It takes a couple of hours. It's sometimes hard to coordinate. And we're going to keep trying to work and get our numbers back up. We were a little bit down this past year in terms of who we're getting done. I mean, you can see the country as a whole is struggling with this. It's a difficult thing to do. Depression screening. Well, as those of you affiliated with the pediatric program know, we started that a couple of years ago with kind of like a depression anxiety screen for parents of children and of adolescents 12 and up with CF, and I feel like we're getting most people at least screened for seeing whether there are anxiety or depression issues. So I think that's generally a good thing. We're the red bar there. So pretty close to 100%. And then in terms of meeting guidelines, this is kind of, I think, one of the more important graphs. And again, I've been a little bit concerned where our trend is going a little on this. We've always been traditionally kind of like one of the top programs in the country for getting people in for 4 visits, getting their PFTs, cultures, and everything done. And we're still way up there, but you can see that it's like over the last 5 years, it's been harder to get people in to meet all those guidelines. So don't take it personally if you're getting hounded and we're calling and calling again. It's really important because the more you see people, the better chance you have of understanding what's going on and being able to make an impact sooner rather than later. Because as you all know, CF can be a silent disease. And so you can have stuff going on in CF and somebody who's looking completely well and have a lot of disease kind of slowly progress. So that's why it's important to be seen at regular intervals. And we know that it's really difficult for many of our families to get here from 3.5 hours away and try to make it in the middle of the week. And there's a lot of different pressures on people, but there is, there's a reason for it. This is also, just to mention, and not the most important thing, but this is actually how we get funded from the CF Foundation to support our center, is who's meeting guidelines. Like if you have, for patients that are followed in the registry, if you're meeting guidelines, you're funded accordingly. And so it's kind of graded based on how many times people are seen and evaluated. This has been something where either we're asking the question a lot more than other people in the country, or we have a bigger problem than most of the country in terms of like exposure to cigarette smoke in households. Like we have a good portion of our pediatric program have a smoker that's in the household, and that's been associated with worse lung function and overall outcomes in CF. Just showing a couple of trends with some chronic therapies. We're kind of on the rise with using azithromycin to kind of block inflammation in the lung, which has been shown to be a pretty safe therapy in cystic fibrosis. There's a few reasons why your child or yourself or your spouse or your family member might not be on this, because there are some reasons not to put people on this medicine sometimes, but overall we're kind of increasing our use of that. And those in the pediatric program, this is kind of more applicable to that than the adults, but I've been a big proponent for using ibuprofen to block lung inflammation, and kind of now we're, I think, the highest user of it in the country. And I don't know if that's good or bad either, but it seems to be, I think, at this point, still a reasonable thing to do. Exercise was a big push over the past few years, and you can see that we're actually, a lot of our patients use exercise as either a primary or a secondary way of helping their lung health and their airway clearance. And I think that's a great thing, and we want to continue to promote that. Just wanted to point out there are certain medications that shouldn't be used in cystic fibrosis. The adults showed this really well in a big study a few years ago. So that, and you guys should feel free to chime in if you're wondering why your child or why you are on certain medications. People who don't have asthma shouldn't really be on inhaled steroids. It doesn't really help your cystic fibrosis out very much. So we've been trying to minimize that, and it looks like we're doing better with that. And in terms of modulator drugs, again, we're that little red bar over to the right. This is a little bit of a lag time. So who's on or can be, or Lumacaftor or ivacaftor, just because of the way approvals came through in terms of when state and the insurance companies kind of put it on their formulary. So when this data came out, we were definitely not up and running on Lumacaftor or ivacaftor, and I think it's going to look a lot different when we get our data this year. And finally, this is a very, I apologize for not being able to see that where you're sitting, but this just plots kind of how we're doing as a center over the past 10 years. So I'm just going to, you can see with the mouse, the arrow that I'm using right here, about 10 years. So what's going on with this graph is that you have BMI percentile, so higher is better, and then you have lung function going up and down, and higher again is better. And so about 10 years ago, we kind of were below the goal for lung function and below the goal for body mass index percentile, and we've kind of moved really close to being in this right upper quadrant where everybody wants to be. So we're kind of as close as you can get to it without just tipping over. We're about 1% away. And it just means that I think, everybody has been doing a great job. The patients, the families, and trying to kind of really implement what we're trying to preach in clinic. And so it's really to your credit that this is happening. And I thank you for that. So I'm going to move it on to Laurie to present the adult data. Thanks.
Hi, I'm Laurie Leclair. I'm the adult program director, and I'll run through similar but different data for the adult program and talk a little bit about how we use the registry data to drive our quality improvement effort. So this is our team, core team, I should say, and many of you out there are probably familiar with this crew. We care for about 80 patients now, so we're actually bigger than the pediatric program, which is a national trend. Ages 18 to 72, so the internists are really getting a workout here as we get more and more patients in their 40s and 50s and beyond. These graphs are similar to the ones that Tom showed you. I'll just remind you a little bit. The blue line is the 10 best performing centers. We're red, and then green is always the national average. And this is the BMI, or body mass index, just a height to weight ratio for patients over the age of 20. And as you can see, what struck me when I was looking at it is that everybody's been pretty flat in all three groups, ourselves included. And actually, the difference between these lines is actually not so much. One BMI point, roughly. And one of the powerful pieces of this data is it lets you look for variability across the country. And I think as we're looking at these over time, there's starting to be less and less variability from center to center. And I think that's actually what we really want. We want to be consistently good across every center. And I think the registry data is evolving in that direction. So we are a little bit leaner than everybody else. We have always been a little bit leaner than everybody else, and we work hard on this, but haven't had a huge impact. If you break down the nutritional groups, the non-CF related diabetes folks tend to have a bit of a higher BMI at our center and nationally than the patients with diabetes. And again, this is, I don't think, unique to our center. It's just one of the things that we worry a lot about in folks, especially who have concomitant diabetes. But the differences aren't huge. A kilo or two, for example, just to give you a sense of the numbers in terms of weight. And I feel as an adult doctor, the implications of nutrition once you've reached your growth potential are different potentially than they are when you're a real little one. So what about our lung function? Here's lung function in patients over the age of 18. This is everybody. We're the red line again, and it's been a bit of a bumpy line. And part of the reason it is a bumpy line is that as people grow into the adult program, our pediatric numbers, since we have a pretty stable cohort, will bump up potentially as someone with lower lung function potentially goes into the 18 group. So this is the denominator of this group is dynamic, because everybody who's aging in will sort of change the numbers, especially in a center of our size, which isn't, 300 or 400 patients, only 80. If you look across just the age group of 18 to 29, here are the numbers, a bit below the national average a couple of years ago, and now sort of sitting right on the national average. This graph shows over the age of 30, and this, I feel, more accurately reflects a stable group of patients. It's not unheard of, but a bit more unusual that we're inheriting new patients into this group. This tends to be folks who've been cared for at our center for a very long time, or at our adult program for a very long time. And I'm happy to report that our lung function in this age group has been amongst the best in the country for over the decade that I have shown here. And you can't read the numbers, but that FEV1 is in the 70s percent range now, and that's median. So half of the group has over the age of 30 has numbers higher than that, which I think is really awesome and speaks to the survivorship down the road. But it's not all perfect. I showed you guys a version of this slide last year at this time, which basically looks similar today. If you pull out the patients with diabetes and look at their lung function in our center, you can see that those numbers tell a much different story. And now these are folks over the age of 18. And our numbers remain below the national average and are quite different. They're in the 50s rather than the 70s. So unlike BMI, where pretty similar numbers overall, this is, I think everyone would agree, a pretty substantial difference in lung function. So we know that diabetes puts a huge threat on lung function as well as nutritional health, and how that interaction really exists and works upon each other we're not clear on, but that relationship is well known. So, we've been aware because of the registry of this data for a long time, and it really drove us to focus an important quality improvement project in this area. And so Marianne Ludlow, who's our dietitian who joined us close to a year ago now, has been the spearhead and has worked with the Jeffords Institute for Quality at the medical school and the university to help with this project. And it's had a multi-pronged effort, but importantly, we embarked on a survey of adult CFRD patients to determine attitudes, barriers, and associations within this group. And as is true of pretty much everybody who works closely in either the adult or pediatric program, we're people of action and we want to do things, we want to fix problems, but we sat on our hands a bit and decided that we needed to better understand the problem before we could try to fix it. And what we learned was actually very interesting, and one was that what are not barriers to diabetes management are actually getting access to drugs and supplies. That wasn't a reported problem by our patients. Fear of needles wasn't an issue, as we had maybe anticipated it might be, or a social stigma, for example, of using insulin, when you're out and around. None of that was troubling our patients. Barriers turned out to be a fear of hypoglycemia or low blood sugars, which was not something that we really had on our radar. And then the burden of finger stick checking or glucose monitoring. So I give you this as just an example of how we as healthcare providers sometimes try to fix things before we really understand the patient perspective, and that is never a fruitful endeavor. So patients told us what's been troubling them about this entity. So we looked for associations as well, and as Tom mentioned, we've been aggressively screening, the whole country has, and we've been doing a nice job here with support from Christine Pryor for depression and anxiety amongst our patients and close family members. So we had a hypothesis that perhaps if you were more anxious or depressed, you might not take care of your diabetes as well, and it turned out that actually wasn't true. And then we found out, which was probably one of the most important epiphanies of this whole effort, and that was that if you had a higher hemoglobin A1C, which means sort of poorer diabetes control, at least in our very small cohort, that didn't mean that your lung function was worse. So we kind of went into this assuming that if your lung function wasn't as good, then your diabetes control must be not as good. And it turns out, granted, our very small group here of patients, only 30 or so, that actually wasn't the case. Oops, I put in some fun animations I forgot about. Sorry, we'll get through here. So we just finished up with that part of the project, and I will thank Marianne again because she worked really hard on getting all the data together, and also the patients who filled out all the surveys and answered our questions. And we presented it to the Northern New England Consortium group that we're a part of with Maine and Dartmouth just a month or so ago. And we are soon to embark on our next phase, which actually is to investigate attitudes and barriers to pulmonary therapies in patients with diabetes, because I think that's been one of the most important things that we've gained out of that first part of the effort. So I would like to give a special thank you to all the patients who helped us review the survey when it was in development and give us feedback about it so that it could be more on target. So Tom mentioned a little bit about exacerbations already, but I wanted to just point out one thing about our center in general with this next slide. So this is the bar graph annual snapshot of what's happening for any outcome. So we've been showing you, Tom and I, the trends over 10 years, but this is the snapshot of what's happening this year, or at least in 2015. And so every blue bar across is the center in the CF Care Center network, and the red bar is pediatrics or adult, depending on the graph that you're looking at. So what struck me is that in terms of exacerbations, we're both top of the country. And I actually think that, as Tom pointed out, that this really reflects an aggressiveness to intervene when someone is sick. That's a very important intervention and potentially is one of the reasons why both the pediatric and the adult programs have very good lung function. They also go on to talk about what % of antibiotics are given in or out of the hospital. And about 80% in pediatrics is given inside the hospital. And we used to look very much that way on the adult program. But over time, we started to drift a little bit. And I think 2016 is going to show us drifting even a bit more, where only 60% of the IV therapy on the adult side is done in the hospital. While both of us tend to treat for 14 days, which is very close to what people do nationally. There's an important clinical trial that's going on right now that might shift some of this, that might help us better understand whether we should be treating for 10 days, 14 days, or 21 days. But the changing adult population, as they grow older, have more complicated lives in terms of jobs and families, et cetera, and we'll hear more about that in a second. The model of really not being able to stay in the hospital for 2 weeks, have that pause out of your busy life, is one that we're having to embrace. And I say having to embrace because that's not been our culture here. But it is becoming our culture, and we are becoming more adept than ever before in facilitating what I think is really good outpatient IV therapy. So for those of you who may have family members coming up through the ranks, this is sort of one of the important shifts that I think we're seeing between the two programs. So I'll summarize is our body mass index is sort of at the national median where it's been for quite some time. Our lung function is either at or well above the national median, especially in our older adults, and is really at a very impressive number in the 70s. And finally finish that with patient support, working to improve quality of the care and better target the appropriate interventions to get better outcomes is really, the whole essence of what this data allows us to do. So each of you or your family members sharing, being willing to have your data be put into this registry is critically important for all of these things. So I think I have one more slide. I don't know if Kitty made it. No. So I like to show this because she does many things for the adult program, but the arduous task of putting in the data is one of them. And number of encounters entered is 1,265, which is an average of 8.1 per patient, and that's the total center. So it's a Herculean task to do this, and as Tom mentioned, this is the revenue stream really that determines the size of our CF Center grant, so it's an important effort. And I'll stop there.